Dr. Sarah Chin had always been told she looked younger than her 32 years. Standing barely 5 feet 4 inches tall with her hair pulled back in a simple ponytail, she often found herself mistaken for a medical student, or intern rather than the accomplished emergency medicine physician she had worked so hard to become. This morning was no different as she walked through the sliding glass doors of St. Mary's Hospital Emergency Department, her white coat crisp and her stethoscope draped around her neck. The emergency room buzzed with its usual controlled chaos. Nurses moved efficiently between beds, their shoes squeaking against the polished linoleum floors. The familiar sounds of monitors beeping, phones ringing, and hushed conversations filled the air. Sarah had been working at St. Mary's for 3 years now, having completed her residency at Johns Hopkins before moving to this mid-sized hospital in suburban Maryland. She loved the variety that emergency medicine offered, never knowing what challenge would walk through those doors next. As she made her way to the nurses' station to check the overnight census, Sarah noticed Dr. Robert Martinez already reviewing charts. Martinez was the department's most senior attending physician, a man in his early 50s with graying temples and a commanding presence that made everyone in the ER take notice when he spoke. He had been practicing emergency medicine for over 20 years and had seen just about everything the job could throw at him. "Morning, Sarah," Martinez nodded as she approached. "We've got a full house today. 3 cardiac cases overnight, 2 motor vehicle accidents, and the usual collection of chest pains and abdominal complaints." Sarah reviewed the patient board, noting the color-coded system that indicated severity levels. Red for critical, yellow for urgent, green for less urgent. Today's board showed a concerning number of red and yellow cases, which meant it was going to be one of those days where every decision mattered and every second counted. The morning proceeded with its typical rhythm. Sarah worked through her assigned patients methodically, treating everything from a construction worker with a lacerated hand to an elderly woman experiencing shortness of breath. Each case required her full attention, careful assessment, and decisive action. This was what she had trained for during those grueling years of medical school and residency, where she had often worked 36-hour shifts and survived on coffee and determination. Around noon, Sarah was in the break room grabbing a quick sandwich when she heard the familiar sound of an ambulance siren growing louder as it approached the hospital. Emergency medical services radio chatter crackled through the overhead speakers, indicating an incoming trauma case. She quickly finished her bite and headed back to the main treatment area. The paramedics wheeled in a middle-aged man who appeared to be in significant distress. From what Sarah could overhear, he was experiencing severe chest pain and had been found collapsed at his workplace. The man's face was pale and sweaty, classic signs that immediately caught her attention. His breathing appeared labored, and even from a distance she could see he was clutching his chest. Dr. Martinez was in the middle of suturing a patient's wound in bed 3 when the ambulance arrived. The charge nurse, Patricia Williams, was coordinating the incoming case and directing the paramedics to bed 1, the trauma bay equipped with all the necessary monitoring equipment and emergency supplies. As the paramedics transferred the patient to the hospital bed, Sarah instinctively moved closer to assess the situation. Her training had taught her to trust her clinical instincts, and something about this patient's presentation triggered her immediate concern. The man appeared to be in his late 40s, overweight, and was experiencing what looked like textbook signs of a cardiac emergency. "What's his story?" Patricia asked the lead paramedic, a veteran EMT named Jake Rodriguez who had been bringing patients to St. Mary's for over a decade. 47-year-old male, found collapsed at work around 11:30 this morning, Jake reported while connecting the patient to the hospital's monitoring equipment. Coworkers said he complained of chest pain and left arm numbness before going down. "We've got him on oxygen, established for access, and his vitals have been unstable during transport." Sarah listened carefully to the report while observing the patient's condition. His heart rate appeared elevated on the monitor, and his blood pressure readings were concerning. She had seen enough cardiac cases during her training and practiced to recognize the urgency of the situation. Dr. Martinez finished with his patient and began walking toward the trauma bay, but he was still several steps away when the patient's condition suddenly deteriorated. The cardiac monitor began alarming loudly, displaying a rhythm that made Sarah's heart skip a beat. The man was going into ventricular fibrillation, a life-threatening arrhythmia that could prove fatal within minutes if not treated immediately. Without hesitation, Sarah stepped forward and began directing the emergency response. "We need the crash cart now!" she called out, her voice carrying the authority that comes from years of training and experience. "Patricia, get me epinephrine and prepare for defibrillation." It was at this moment that Dr. Martinez, still approaching the scene, noticed Sarah taking charge of the situation. In his view, protocol dictated that as the senior attending physician, he should be leading the resuscitation effort. From his perspective, Sarah was overstepping her bounds by immediately jumping into action without waiting for his direction. "Move aside, student!" Martinez shouted across the busy emergency room, his voice cutting through the noise of alarms and urgent conversations. "I'll handle this case." The words hung in the air like a thunderclap. Every nurse, technician, and physician within earshot turned to look at the scene unfolding in the trauma bay. Sarah felt the familiar sting of being dismissed based on her appearance and assumed inexperience, but this was not the time for personal feelings. A man's life hung in the balance, and professional protocol demanded that she step aside for the senior physician. But Sarah had already begun her assessment, and had her hands on the patient. She could feel his pulse becoming weaker and more irregular. The monitor continued its urgent alarming, and she knew that every second of delay could mean the difference between life and death for this patient. "Dr. Martinez," she said firmly, not moving from her position, "this patient is in VFib. We need to defibrillate immediately." Martinez was still making his way through the crowded emergency room, navigating around other beds and equipment. The physical distance between him and the patient meant precious seconds were ticking away while the man's heart was in a potentially fatal rhythm. Sarah made a split-second decision that would define not only this emergency but her entire career at St. Mary's Hospital. Instead of stepping aside as instructed, she continued with the resuscitation protocol. Charging to 200 joules, she announced to the team, following advanced cardiac life support guidelines that she had memorized and practiced countless times. The defibrillator hummed as it charged to the appropriate energy level. Patricia and the other nurses worked seamlessly with Sarah, their experience allowing them to anticipate each step of the process. The respiratory therapist prepared to bag mask ventilate the patient, while the pharmacist stood ready with emergency medications. "Everyone clear," Sarah announced, checking to ensure no one was touching the patient or the bed before delivering the electrical shock. She pressed the paddles firmly against the man's chest and activated the defibrillator. The patient's body jerked slightly as the electrical current passed through his heart. Everyone in the trauma bay watched the cardiac monitor intently, waiting to see if the shock would restore a normal rhythm. For a moment that felt like an eternity, the monitor showed a flat line before suddenly displaying an organized rhythm. "We've got him back," Patricia announced, relief evident in her voice as she checked the patient's pulse. The man's color began to improve slightly, and his breathing became more regular. But this was only the beginning of what would prove to be an extraordinarily challenging case. As Sarah continued to monitor the patient's condition, she noticed subtle changes that suggested this cardiac event was more complex than a typical heart attack. The man's neurological responses seemed inconsistent, and there were other clinical signs that didn't quite fit the standard presentation. Dr. Martinez had finally reached the trauma bay and was now standing beside Sarah, observing the patient's condition. Despite his initial outburst, he was experienced enough to recognize that the immediate crisis had been managed effectively. However, the tension in the room was palpable, and it was clear that the earlier exchange had not gone unnoticed by the emergency department staff. "What's his current status?" Martinez asked, falling into his role as the attending physician while Sarah continued her assessment. "Pulse is weak but regular, blood pressure is still low, and I'm concerned about some neurological findings," Sarah reported professionally, maintaining her focus on the patient despite the awkward dynamics of the situation. As they worked together to stabilize the patient, Sarah's clinical instincts continued to tell her that something more complex was happening. The man's presentation included elements that suggested possible complications beyond a simple myocardial infarction. She began to suspect that they might be dealing with a case that would challenge even the most experienced emergency physicians. The next few minutes would prove to be a turning point, not just for the patient fighting for his life, but for Sarah's standing in the emergency department and her relationship with her colleagues. What started as a routine day in the ER was about to become a medical case that would test everyone's skills, judgment, and ability to work together under extreme pressure. The patient's condition remained unstable, and Sarah found herself in the unique position of having initiated care while now working alongside the senior physician who had publicly questioned her authority. The emergency room staff continued their work around them, but the underlying tension was unmistakable. As alarms continued to sound and the patient's vital signs fluctuated, Sarah realized that this case was far from over. In fact, the most challenging aspects of this medical emergency were just beginning to unfold, and how she handled the next crucial minutes would determine not only the patient's outcome but also her future in the department where she had worked so hard to establish herself as a competent and respected physician. The patient's heart rhythm had stabilized temporarily, but Sarah's trained eye caught subtle changes that made her increasingly concerned. While Dr. Martinez focused on reviewing the paramedics' report and ordering standard cardiac protocols, Sarah noticed that the man's pupils were responding sluggishly to light, and there was a slight asymmetry in his facial features that hadn't been present when he first arrived. "Dr. Martinez," Sarah said carefully, maintaining a professional tone despite the earlier confrontation, "I think we need to consider that this might not be a straightforward cardiac case." Martinez looked up from the chart he was reviewing, his expression showing mild irritation. "The presentation is classic for acute myocardial infarction. We need to get him to the cardiac catheterization lab immediately." Sarah understood the logic behind his assessment. The patient was a middle-aged male with chest pain, sweating, and had experienced ventricular fibrillation. These were indeed textbook signs of a heart attack. However, her clinical instincts, honed through years of training and thousands of patient encounters, were telling her something different. "I agree the cardiac symptoms are prominent," she persisted. "But look at his neurological presentation. The pupil response is concerning, and I noticed some facial asymmetry developing over the past few minutes." Patricia, who had been monitoring the patient's vital signs, looked up with interest. As an experienced emergency nurse, she had learned to trust the observations of physicians who took the time to perform thorough assessments. "His speech was also slurred when he briefly regained consciousness," she added, supporting Sarah's observation. The patient stirred slightly on the bed, his eyes fluttering open for a moment before closing again. Sarah immediately moved to his side and began performing a rapid neurological assessment. She checked his response to verbal commands, tested his grip strength, and observed his facial movements carefully. "Sir, can you tell me your name?" Sarah asked in a clear, calm voice. The man attempted to speak, but his words were garbled and difficult to understand. More alarming to Sarah was the fact that the right side of his face seemed to droop slightly, and when she asked him to squeeze her hands, his left grip was noticeably weaker than his right. "Dr. Martinez," Sarah said urgently, "I believe this patient is having a stroke in addition to his cardiac issues. We need to consider a dual pathology here." Martinez paused in his documentation and looked more closely at the patient. As a senior physician with 2 decades of experience, he had certainly seen cases of simultaneous cardiac and neurological events, though they were relatively uncommon. The pressure of managing a busy emergency department, combined with the statistical likelihood that chest pain in a middle-aged male indicated cardiac disease, had initially focused his attention on the heart-related symptoms. "Show me what you're seeing," he said, setting down his pen and moving to examine the patient himself. Sarah demonstrated the neurological findings she had observed, pointing out the facial asymmetry, the weakness on one side of the body, and the speech difficulties. As Martinez performed his own examination, his expression gradually changed from skeptical to concerned. "You're right," he admitted, his voice taking on a more collaborative tone. "This looks like we're dealing with both acute coronary syndrome and a cerebrovascular accident. The realization that they were facing a dual emergency significantly complicated their treatment approach. Standard protocols for heart attacks sometimes conflicted with optimal stroke care, particularly when it came to blood-thinning medications and blood pressure management. Sarah felt a surge of vindication that her clinical observations had been accurate, but there was no time to dwell on the earlier conflict. The patient's life depended on their ability to manage both conditions simultaneously. "We need to get neurology down here immediately," Sarah said, already reaching for the phone. "And we should get a CT scan of his head before we proceed with any cardiac interventions." Martinez nodded in agreement. "Patricia, call Dr. Jennifer Walsh in neurology and tell her we need an emergency consult. Also, let's get this patient to CT as soon as possible." The next 20 minutes became a carefully orchestrated dance of medical professionals working to address multiple life-threatening conditions. The CT scan revealed what Sarah had suspected. The patient had suffered a significant stroke affecting the left side of his brain, which explained the weakness on his right side and his speech difficulties. Meanwhile, the cardiac enzymes that had been drawn showed elevated levels consistent with heart muscle damage. An electrocardiogram confirmed that the man had indeed suffered a heart attack. The challenge now was determining the best course of treatment for a patient experiencing both conditions simultaneously. Dr. Walsh arrived in the emergency department just as the patient was being returned from radiology. A tall, confident woman in her 40s, Walsh was known throughout the hospital for her expertise in stroke care and her ability to make rapid decisions in complex neurological cases. "What do we have?" Walsh asked, immediately reviewing the CT images on the computer screen. Sarah provided a concise summary of the patient's presentation, the timeline of events, and the dual findings. Walsh listened carefully while examining the brain scans, her experienced eye identifying the areas of damage and assessing the potential for recovery. "This is a significant stroke," Walsh confirmed. "The affected area controls speech and motor function on the right side of the body. The good news is that we're still within the window for thrombolytic therapy, but we need to coordinate carefully with cardiology given his concurrent heart attack." The dilemma they faced was complex. Thrombolytic medications, which could help dissolve the blood clot causing the stroke, might also worsen bleeding complications from the heart attack. Conversely, some cardiac treatments could potentially worsen the stroke or interfere with neurological recovery. Dr. Martinez had called the on-call cardiologist, Dr. Michael Patterson, who arrived within minutes of the neurology consult. Patterson was known for his methodical approach and his ability to collaborate effectively with other specialists in challenging cases. "This is definitely a case where we need to think outside the standard protocols," Patterson said after reviewing all the available information. "We need to prioritize the most immediate threat to life while considering the long-term implications of our treatment choices." As the three specialists discussed treatment options, Sarah found herself in the unique position of having identified the dual pathology that was now driving the entire case management strategy. Her initial clinical observations had proven crucial in ensuring that the patient received appropriate care for both conditions. The conversation between the specialists was intense and technical, covering topics like bleeding risk, optimal blood pressure targets, and timing of various interventions. Sarah listened carefully, contributing observations about the patient's evolving condition and asking questions that helped clarify the decision-making process. "I think our best approach is a modified protocol," Dr. Walsh finally suggested. "We can use a reduced dose of thrombolytics for the stroke while closely monitoring for cardiac complications. We'll need to hold off on some of the more aggressive cardiac interventions until we see how he responds to the stroke treatment." Dr. Patterson agreed with the collaborative approach. "We can optimize his cardiac status medically while giving the stroke treatment a chance to work. If his neurological condition stabilizes, we can then consider more invasive cardiac procedures if needed." As the treatment plan was implemented, Sarah continued to monitor the patient closely. She had become, in many ways, the physician most familiar with his case, having been present from the moment of his arrival and having identified the complexity of his condition. The patient's response to treatment was gradual but encouraging. Over the next 2 hours, his speech became clearer, and some strength returned to his affected limbs. His cardiac rhythm remained stable, and his vital signs showed steady improvement. During this time, word had spread throughout the emergency department about the complex case and Sarah's role in identifying the dual pathology. Nurses and other staff members had witnessed the initial confrontation between Sarah and Dr. Martinez, and many had observed how her clinical acumen had ultimately guided the successful treatment approach. Patricia approached Sarah during a quiet moment between patient assessments. "That was excellent clinical work," she said quietly. "A lot of people would have missed the neurological signs given how dramatic the cardiac presentation was." Sarah appreciated the recognition, but her primary focus remained on patient care. "It's what we're trained to do," she replied. "The patient is what matters most." However, she couldn't help but reflect on the morning's events and how they had unfolded. Her decision to continue with resuscitation despite being told to step aside had been vindicated by the patient's survival. More importantly, her careful clinical observation had identified a complex medical condition that required specialized care. Dr. Martinez had been notably absent from direct patient care for the past hour, focusing instead on administrative tasks and other cases. Sarah sensed that he was processing the events of the day and perhaps reconsidering his initial assumptions about her capabilities. As evening approached and the patient's condition continued to stabilize, Sarah began to feel cautiously optimistic about his prognosis. Both the stroke and heart attack had been identified and treated promptly, giving him the best possible chance for recovery. But she also realized that the day's events had created a new dynamic in the emergency department. Her relationship with Dr. Martinez would need to be addressed, and her standing among her colleagues had undoubtedly been affected by the public confrontation and subsequent clinical success. The patient was eventually transferred to the intensive care unit for continued monitoring and rehabilitation. As Sarah completed her documentation and prepared for the next case, she reflected on how 8 minutes of critical decision-making had not only saved a man's life but had also fundamentally changed her position within the medical team. The emergency department continued its relentless pace around her, but Sarah knew that something significant had shifted. Her clinical competence had been tested under the most challenging circumstances, and she had proven herself capable of managing complex medical cases with skill and confidence. Little did she know that the most dramatic developments of this extraordinary day were still to come. As the patient was being transferred to the intensive care unit, Sarah felt a moment of satisfaction knowing that her clinical judgment had made a crucial difference in his care. However, her relief was short-lived. The emergency department radio crackled to life with an urgent transmission that immediately captured everyone's attention. "St. Mary's Emergency, this is Rescue 1. We're en route with multiple casualties from a major vehicle accident on Interstate 95. We have at least 4 critically injured patients, estimated arrival in 12 minutes. Please prepare for mass casualty protocol." The charge nurse, Patricia, immediately activated the hospital's mass casualty response system. Overhead pages echoed throughout the building, calling additional medical staff to the emergency department. Sarah had trained for these scenarios during her residency, but actual mass casualty events were relatively rare and always tested the limits of the emergency team's capabilities. Dr. Martinez, who had been somewhat subdued following the earlier cardiac case, immediately stepped into his role as the senior attending physician. "Sarah, I need you to take charge of Trauma Bay 2. We're going to need all hands on deck for this." The acknowledgement of her capabilities, implicit in his assignment of a Trauma Bay, was not lost on Sarah. Despite their earlier confrontation, Martinez was demonstrating trust in her clinical abilities when it mattered most. Within minutes, the emergency department transformed into a carefully orchestrated center of controlled chaos. Additional nurses arrived from other units, respiratory therapists prepared ventilators, and the blood bank was notified to have emergency blood products ready. The hospital's trauma surgeon, Dr. Elizabeth Kumar, arrived ahead of schedule after hearing the initial radio call. "What's our ETA on the first ambulance?" Dr. Kumar asked as she reviewed the preliminary information. 8 minutes now," Patricia responded, coordinating with the EMS dispatch center. We have reports of a multi-vehicle collision involving a commercial truck and 3 passenger vehicles. Initial triage suggests 2 red tags, 1 yellow, and 1 green. The color-coding system used by emergency medical services helped hospital staff prepare for the severity of incoming patients. Red tags indicated life-threatening injuries requiring immediate attention, yellow meant urgent but stable, and green represented less critical cases. Sarah began setting up her assigned trauma bay, ensuring that all necessary equipment was functional and easily accessible. She had learned during her training that preparation and organization could mean the difference between life and death when dealing with severely injured patients. The first ambulance arrived exactly when predicted, its sirens cutting through the afternoon air as it pulled up to the emergency department's ambulance bay. Sarah could see through the window that the paramedics were performing CPR on their patient as they prepared to transfer him into the hospital. "This is our red tag priority," called out Jake Rodriguez, the same paramedic who had brought in the cardiac patient earlier that day. 28-year-old male, driver of one of the passenger vehicles. Severe chest trauma, possible internal bleeding, and he's been in and out of consciousness during transport. As the paramedics transferred the young man to Sarah's trauma bay, she immediately began her primary assessment. The patient was conscious but clearly in severe distress. His breathing was labored, and Sarah could see obvious deformity in his chest wall that suggested multiple rib fractures. "What's his name?" Sarah asked while beginning her examination. "David Thompson," responded the paramedic. "No known medical history, but witnesses said he was trapped in his vehicle for about 20 minutes before we could extract him." Sarah's hands moved efficiently as she performed her trauma assessment. She could feel crepitus, the crackling sensation that indicated air under the skin, suggesting that one of his broken ribs had punctured a lung. His blood pressure was dropping, and his heart rate was elevated, classic signs of possible internal bleeding. "I need chest x-rays immediately, and let's get 2 large-bore IVs started," Sarah called out to her team. "Also, notify the blood bank that we may need O-negative blood." As she worked on David Thompson, Sarah was aware of intense activity in the other trauma bays. She could hear Dr. Martinez directing care for what sounded like a patient with severe head injuries, while Dr. Kumar was managing someone with multiple orthopedic injuries. The chest X-ray confirmed Sarah's clinical suspicion. David had a pneumothorax, a collapsed lung caused by air leaking from the punctured lung tissue. Without immediate intervention, the condition could rapidly progress to a life-threatening tension pneumothorax. "I need a chest tube tray," Sarah announced, preparing to perform the procedure that would re-expand his lung and potentially save his life. As Sarah began the chest tube insertion, she noticed that David's vital signs were continuing to deteriorate despite the oxygen therapy and, for fluids they had administered. His blood pressure was dropping more rapidly than she would have expected from the pneumothorax alone, suggesting that he might have significant internal bleeding from his other injuries. "David, can you hear me?" Sarah asked while working on the chest tube placement. The young man's eyes opened briefly, and he nodded slightly, but Sarah could see that he was becoming increasingly confused and lethargic. These were concerning signs that suggested either worsening blood loss or possible brain injury that hadn't been immediately apparent. The chest tube procedure went smoothly, and David's breathing immediately improved as his collapsed lung re-expanded. However, his blood pressure continued to drop, and Sarah realized she needed to identify and address the source of his ongoing blood loss. "I need a fast scan," she called out, referring to a bedside ultrasound examination that could quickly identify internal bleeding in the abdomen or around the heart. As Sarah performed the ultrasound examination, she discovered what she had feared. There was free fluid in David's abdomen, indicating significant internal bleeding that would require immediate surgical intervention. "Dr. Kumar," Sarah called across the emergency department, "I need you to see this patient as soon as possible. He's got a pneumothorax that I've treated, but he also has significant internal bleeding that's going to need surgical exploration." Dr. Kumar, who was in the middle of evaluating another trauma patient, looked up and assessed the urgency in Sarah's voice. Give me 2 minutes to finish this primary survey, and I'll be right over. While waiting for the trauma surgeon, Sarah continued to monitor David's condition closely and began preparing him for emergency surgery. She knew that time was critical in cases of internal bleeding, and every minute of delay could increase his risk of complications or death. The second ambulance arrived as Sarah was working on David, bringing in the patient who had been triaged as the second red tag priority. She could hear the commotion as that patient was brought into Dr. Martinez's trauma bay, but she forced herself to maintain focus on her own critically injured patient. Dr. Kumar arrived at Sarah's trauma bay just as David's blood pressure took another significant drop. The trauma surgeon quickly reviewed the ultrasound findings and examined the patient herself, confirming Sarah's assessment. He needs to go to the OR immediately, Dr. Kumar decided. This looks like a grade 4 splenic laceration at minimum. Good work identifying this quickly. As the surgical team prepared to take David to the operating room, Sarah felt a familiar mix of satisfaction and concern. She had successfully identified and addressed 2 life-threatening conditions, but the young man's survival would ultimately depend on the surgical repair of his internal injuries. Sarah, Dr. Kumar said as David was being wheeled away. That was excellent trauma care. Your quick identification of both the pneumothorax and the internal bleeding probably saved his life. The recognition from the trauma surgeon, who was known for her exacting standards and expertise, meant a great deal to Sarah. However, she had little time to reflect on the compliment as the third ambulance was arriving with another critically injured patient. This case turned out to be a middle-aged woman who had been a passenger in one of the vehicles involved in the accident. She had suffered significant orthopedic injuries but was hemodynamically stable, meaning her vital signs were acceptable, and she wasn't in immediate danger of death. As Sarah began treating the woman's obvious fractures and coordinating her care with orthopedic surgery, she became aware of increasing tension in the trauma bay where Dr. Martinez was working. She could hear raised voices and urgent commands that suggested his patient was not responding well to treatment. Sarah, Patricia called out. Dr. Martinez needs your help in Trauma Bay 1. Can you come over as soon as you get your patient stabilized? Sarah quickly completed her assessment and treatment of the woman with orthopedic injuries, ensuring that her fractures were properly splinted and her pain was controlled. She then hurried to Trauma Bay 1 to see what assistance Martinez might need. What she found was a chaotic scene centered around a teenage girl who appeared to be in critical condition. The patient was unconscious, and Sarah could immediately see signs of severe brain injury. Her pupils were unequal and poorly responsive to light, and her body showed the abnormal posturing that indicated significant neurological damage. What's her story? Sarah asked as she stepped into the trauma bay. 16-year-old female, passenger in the commercial truck, Martinez replied, clearly stressed by the complexity of the case. Massive head trauma, possible spinal injuries, and she's been progressively deteriorating since arrival. Sarah quickly assessed the situation and realized that this patient represented one of the most challenging cases she had ever encountered. The teenager's injuries were severe, and her young age made the potential tragedy even more heartbreaking. As Sarah began assisting with the girl's care, she noticed that Martinez seemed overwhelmed by the complexity of managing multiple severe trauma cases simultaneously. The earlier events of the day, combined with the pressure of the mass casualty situation, appeared to be affecting his usual commanding confidence. Let me take point on this case, Sarah offered, recognizing that fresh eyes and a clear head might be exactly what the situation needed. Martinez looked at her for a moment, and Sarah could see him weighing his options. The pride and hierarchy that had created their earlier conflict seemed less important in the face of a critically injured teenager who needed the best possible care. Do it, he said simply, stepping back to allow Sarah to take charge of what would prove to be the most challenging case of her career. As Sarah began directing the teenager's care, she was unaware that the events of the next few minutes would fundamentally transform not only the outcome for this critically injured patient, but also her standing within the entire hospital system. Taking charge of the critically injured teenager's care, Sarah immediately began a systematic assessment of the girl's neurological status. The 16-year-old, later identified as Emma Rodriguez, had suffered what appeared to be a severe traumatic brain injury in the commercial truck accident. Her Glasgow Coma Scale score was alarmingly low, indicating profound neurological compromise. "What's her intracranial pressure?" Sarah asked the nurse monitoring Emma's vital signs. "We don't have an ICP monitor placed yet," responded the trauma nurse. "But her pupils are becoming increasingly sluggish, and her blood pressure is rising while her heart rate drops." Sarah recognized these as classic signs of increased intracranial pressure, a life-threatening condition that required immediate intervention. The Cushing's triad of hypertension, bradycardia, and irregular breathing patterns suggested that Emma's brain was swelling dangerously within the confined space of her skull. "We need neurosurgery down here immediately," Sarah directed, while beginning emergency measures to reduce the pressure in Emma's brain. "Start hyperventilation, give me mannitol, and let's get her head elevated to 30 degrees. As the team implemented these interventions, Sarah noticed that Emma's left pupil had become fixed and dilated, a sign that suggested imminent brain herniation. This was a neurosurgical emergency that could prove fatal within minutes if not addressed immediately. "Page Dr. Richardson from neurosurgery," Sarah ordered, referring to the hospital's most experienced brain surgeon. "Tell him we have a pediatric patient with signs of impending herniation who needs immediate surgical intervention." While waiting for the neurosurgeon, Sarah coordinated with radiology to get emergency CT scans of Emma's brain. The images would provide crucial information about the extent of her injuries and guide surgical decision-making. Every minute was precious in cases of severe traumatic brain injury. Dr. Richardson arrived in the emergency department within 10 minutes of being paged, moving with the purposeful urgency that characterized his approach to neurosurgical emergencies. A tall, methodical surgeon in his early 60s, Richardson had performed thousands of brain surgeries and had a reputation for taking on the most challenging cases. "Show me what we have," Richardson said, immediately reviewing the CT scans that had just been completed. The images revealed a devastating picture. Emma had suffered a large epidural hematoma, a collection of blood between her skull and brain tissue that was compressing vital brain structures. Additionally, there was evidence of significant brain swelling that was increasing the pressure within her skull to dangerous levels. "This needs immediate surgical decompression," Richardson concluded without hesitation. "We need to get her to the OR within the next 15 minutes if we're going to give her any chance of survival." As the surgical team prepared Emma for emergency transport to the operating room, Sarah found herself in the position of coordinating multiple aspects of her care. She needed to ensure that Emma remained medically stable during the transport, while also communicating with the surgical team about her condition and treatment. "Her blood pressure is becoming increasingly labile," Sarah reported to Dr. Richardson as they prepared to move Emma. "I've started her on a nicardipine drip to control the hypertension, and we're maintaining her CO2 levels between 32 and 35. Richardson nodded approvingly at Sarah's management approach. "Excellent. Those are exactly the parameters we want to maintain during transport and surgery. Can you accompany us to the OR to help with the initial surgical preparation?" The request was unusual but made sense given Sarah's intimate knowledge of Emma's case and her demonstrated competence in managing complex neurological emergencies. As they rushed through the hospital corridors toward the operating room, Sarah continued to monitor Emma's vital signs and adjust medications as needed. In the operating room, Sarah assisted with the initial positioning and preparation while Dr. Richardson and his team prepared for the emergency craniotomy. The surgery would involve removing a portion of Emma's skull to relieve the pressure and evacuate the blood clot that was compressing her brain. "Sarah, I want you to monitor her neurological status throughout the procedure," Richardson instructed. "Any changes in her pupillary responses or motor function could indicate complications that we need to address immediately." The surgery proceeded with methodical precision as Dr. Richardson worked to save Emma's life. Sarah found herself serving as a bridge between the surgical team and the critical care aspects of Emma's management, a role that required both technical knowledge and the ability to think quickly under extreme pressure. After 2 hours of intensive surgery, Dr. Richardson successfully removed the blood clot and placed a monitor to continuously track the pressure within Emma's brain. The immediate crisis had been addressed, but Emma's recovery would depend on her brain's ability to heal from the trauma it had sustained. "The surgery went as well as we could have hoped," Richardson told Sarah as they prepared Emma for transport to the intensive care unit. "Her brain pressure has normalized, and we were able to control the bleeding. Now it's a matter of supportive care and waiting to see how she responds." As Emma was settled into the intensive care unit, Sarah reflected on the extraordinary day she had experienced. From the initial cardiac emergency that had led to her public confrontation with Dr. Martinez, through the complex dual pathology case, to the mass casualty event, and now Emma's life-saving brain surgery, she had been tested in ways she had never anticipated. Word of Sarah's performance throughout the day had spread throughout the hospital. Nurses, residents, and attending physicians had witnessed her clinical competence, her ability to work under pressure, and her skill in managing some of the most challenging cases the emergency department had seen in months. Dr. Martinez approached Sarah as she was completing her documentation in the intensive care unit. His expression was thoughtful, and Sarah could see that he was choosing his words carefully. "Sarah, I owe you an apology for this morning," he began. "When I called you a student and told you to move aside, I was wrong. Your clinical judgment today has been exceptional, and your care of these patients has been exemplary." Sarah appreciated his acknowledgement, but she was also aware that their working relationship would need to evolve beyond this moment. "We're all here to take care of patients," she replied diplomatically. "That's what matters most. I think there's more to discuss than just patient care," Martinez continued. "Dr. Kumar, Dr. Richardson, and I have been talking about your performance today. We're recommending you for the position of Assistant Emergency Department Director." The offer was unexpected and represented a significant recognition of her abilities. The Assistant Director position would give Sarah greater authority in the emergency department and put her on a path toward eventual leadership of the entire department. "I'm honored by the recommendation," Sarah responded. "But I want to make sure this is based on my overall qualifications and not just today's events." "Today's events were extraordinary," Martinez acknowledged. "But they demonstrated qualities we've been observing in you for months. Your clinical acumen, your ability to lead under pressure, and your commitment to excellent patient care make you an ideal candidate for increased responsibility." As Sarah considered the offer, she thought about Emma Rodriguez, still fighting for her life in the intensive care unit. The teenager's outcome remained uncertain, but Sarah knew that her quick recognition of the neurological emergency and her coordination with the surgical team had given Emma the best possible chance for survival. Over the following days, Sarah learned that David Thompson, the young man with internal injuries from the vehicle accident, had successfully recovered from his surgery and was expected to make a full recovery. The cardiac patient from the morning had also shown steady improvement, with both his heart function and neurological symptoms gradually resolving. Emma's recovery proved to be more challenging, as was expected with such severe brain trauma. However, she gradually regained consciousness over the course of a week and began showing signs of neurological improvement that exceeded the initial predictions. 3 weeks after that transformative day in the emergency department, Sarah was officially promoted to Assistant Director of Emergency Medicine. The promotion ceremony was attended by hospital leadership, her colleagues from the emergency department, and even some of the patients whose lives she had helped save. Dr. Martinez, who had become one of Sarah's strongest supporters, introduced her at the ceremony with words that reflected how much their professional relationship had evolved. "Dr. Sarah Chen exemplifies everything we hope to see in emergency medicine," he said to the assembled group. "She combines technical excellence with clinical judgment, compassion with decisiveness, and individual competence with team leadership. The patients of this hospital are fortunate to have her caring for them." As Sarah accepted her new position, she reflected on how 8 minutes of critical decision-making had indeed transformed not only several patients' lives but also her own career trajectory. Her willingness to trust her clinical instincts, even in the face of public criticism, had ultimately demonstrated her readiness for greater responsibility and leadership. Emma Rodriguez, who had been transferred to a rehabilitation facility, sent Sarah a handwritten thank you note several months later. In shaky handwriting that reflected her ongoing recovery, Emma wrote, "Thank you for saving my life. I know you fought for me when it mattered most." The note served as a reminder to Sarah of why she had chosen medicine in the first place: the opportunity to make a real difference in people's lives during their moments of greatest need. Her promotion to assistant director would give her the platform to train other physicians, improve emergency department protocols, and ensure that future patients received the same level of dedicated, competent care that had characterized that extraordinary day. Looking back, Sarah realized that the confrontation that had seemed so devastating in the moment had actually been a catalyst for demonstrating her true capabilities. Dr. Martinez's initial challenge to her authority had, paradoxically, created the opportunity for her to prove herself under the most demanding circumstances possible. The emergency department continued its relentless pace, with new challenges and critical cases arriving daily. But Sarah now faced these challenges with the confidence that comes from having been tested under fire, and having emerged not only successful but transformed. Her journey from being dismissed as a student to commanding the entire emergency department in just 8 transformative minutes had taught her that sometimes the greatest professional growth comes from the most difficult moments. In her new role as assistant director, Sarah would go on to implement training programs that emphasize the importance of clinical observation, the value of trusting one's instincts, and the critical need for all team members to feel empowered to speak up when patient safety was at stake. The lessons learned during those 8 minutes would influence emergency medicine practices far beyond the walls of St. Mary's Hospital, ensuring that future physicians would be better prepared to handle the complex challenges that define emergency medicine.